Hi, this is Brian Kim. I want to share with you this case of a patient who was referred to me. This patient has a dislocated three-piece lens and also is a high myope. And why is this a challenge when you're doing IOL exchanges and the Yamane technique? Well, because of low scleral rigidity. If you have low scleral rigidity, anything that requires force on the sclera is going to cause a sclera to collapse. And this just reduces your level of control. And that goes from, the beginning of trying to place your trocar to placing the scleral needles for the lens fixation for the Yamane technique. And so this is really an important part of recognizing this potential challenge. This patient has a high axial length and the lens power is like in the teens. And so you know ahead of time that you're going to have reduced scleral rigidity, which means the eye is going to tend to just collapse when you try to manipulate the sclera. And so it's very important to maximize infusion. But even if you do everything right, sometimes it's just a struggle. And you're going to see some elements of that in this case. So you can see this patient has a severely dislocated three-piece lens. And so I go to lower mag. This is a trocar. I indent about 4 millimeters back using the cotton tip to turn the eye. And then I'm going to go around 3 millimeters or so away from that mark. I'm tunneling with the trocar needle, tunnel, and then I enter. As I pull it out, one thing I'll notice, you see the trocar is not sitting sideways, which makes me worried that it might not have created a good scleral tunnel, or perhaps because it's just the sclera is too thin. Hard to know, but you'll see what I mean as the case progresses. So I use the tip of the cannula and make a mark on the limbus on one side and then the other side, using the cannula to find 180 degrees apart. And this is a fixed caliper from Epsilon. This is 2.5 millimeters posterior to the limbus. You can see how much the sclera indents as I make my marks. Again, another sign that this could be a potential challenge. Again, always dry the surface of the conj when you do this part of the case. Otherwise, the indentation and ink marks won't work very well. So again, 2.5 millimeters back, posterior radial, and then 2 millimeters adjacent. And then using that inked cannula. I really love that. And so again, this is a small pupil. Look, see how much the eye collapses even with these maneuvers. And I haven't really gone into the eye yet. And so I make a subincisional episcleral incision, and that's going to be for the iris hooks. I make another incision and I'm going to put some dispersive viscoelastic to fill the anterior chamber, thinking this is going to help me with the fact that this eye is collapsing, and of course it does not. And so even though you fill the eye with the viscoelastic, you can see there's still a lot of collapsing of the eye with each of the incisions. You can see there's quite a bit of collapsing of the eye when I'm making my incisions, despite having that dispersive viscoelastic in. So again, each of these incisions are for the iris hooks, also my paracentesis incisions to help me remove the lens, as well as the contralateral limbal incision to externalize the leading haptic for my modified Yamane technique. And so here comes the iris hooks. I start with the subincisional one first. And this is, again, really easy to do if you know what you're doing and you've done it many times. You just hold the hook perpendicular with the forceps, twirl the stopper so the hook is pointed down, hooking the iris and then cinching it down. It really isn't that hard. It just comes with practice like anything. And if you do enough of these cases, this part goes rather quickly. And you want to use an iris hook. I would not put any other hardware like a Malyugin ring or any other type of pupil expansion devices in this context, because those instruments are fully inside the eye, and God forbid, what if you're doing the case and the thing slips off and then it ends up falling into the vitreous space. I don't think it makes sense to use something like that when it's fully inside the eye. Again, you can see I'm able to titrate and customize the amount of pupil retraction with the iris hooks. And so just going slowly, step by step here, holding the hook, again, perpendicularly, twirling the stopper so it's pointed down, and then cinching it down with 2 forceps. I'm going to push some more dispersive viscoelastic to coat the corneal endothelium, and then this is the 3mm incision. You can see, despite my best efforts, it really is a challenge, and you can see how much the eye is collapsing. You might wonder why I haven't put in AC maintainer, and that is something that I could have done differently here. But in my experience, sometimes you put in the AC maintainer and it can actually cause more lens instability. That lens is already unstable, and by putting that high infusion pressure from anteriorly, I just worry that it's going to cause the lens to become more unstable. Again, I don't have any experiences placing pars plana infusion, and so that could be another way to help mitigate that. But since I always use an AC maintainer, I get a little bit worried in these contexts. So I bisect the lens completely in half with microforceps and scissors, and I like to go after the right side piece because of the way the haptic is pointed away from me. I'm able to pull it out easily. Which I did there. I just nudged it with the forceps, and then I'm grabbing that trailing haptic with the two-handed technique, pulling it up, and then grabbing the edge of the optic there, the cut edge, and then pulling it out, using the other forceps to protect the cornea. Again, quite a bit of collapsing of the eye. I didn't put a AC maintainer in, but I'm putting it in now. I had to widen the incision, and then here it goes. It's a 20 gauge Lewicki AC maintainer, and then I go ahead and do the vitrectomy. I have not encountered any vitreous at all during the entire maneuver so far. These are all things you have to think about. If you put the AC maintainer early, how would that have affected the IOL removal part of it? Again, because I don't tend to have vitreous when I'm taking lenses out in this context, I decided to do it without the AC maintainer. So you can see now I'm bending my needles. Those are the 30 gauge thin wall needles, that clear hub on the needle. And I make sure that the right side needle is facing towards me, the left side needle is facing away from me. The 25 gauge needle has a blue colored needle, and you want to have that needle bent so that it's facing the right side, which will be the approach of the leading haptic. This is the sensor lens. I'm placing it into the cartridge plane, making sure it's seated in, and as I bring the wings together, you want the optic to collapse concavely. The leading haptic goes out through the barrel, and the trailing haptic comes out on the back end. You can see that the trailing haptic, once it's in the cartridge, is above the cartridge barrel, and then now you can use the plunger and slide it through, making sure you won't accidentally amputate that trailing haptic. So this is the 25 gauge needle docking technique. I'm placing the injector in, pointing the barrel to the left. My assistant is delivering the lens. The leading haptic is coming out. I'm just going to direct the haptic towards the 25 gauge needle, dock it on the bevel of the needle, and then it starts to internalize into the needle. And as the lens is being delivered, I'm able to pull the 25 gauge needle out, and the haptic has come out. And then I take over, making sure the optic comes out flat. And as I continue to deliver the lens, make sure the trailing haptic is pointed to the right. Inject some dispersive viscoelastic to, again, push the optic down and coat the corneal endothelium. And this is the right side needle. I'm going to tunnel from the first point to the second point, holding the eye in the neutral position with 0.12 forceps. And then I'm going to very gently, with non-toothed microforceps, slide the trailing haptic in. Dock the haptic on the bevel of the needle. Infusion is on, as you can tell here. Internalizing the trailing haptic into the right side needle, disengaging the needle from the syringe, internalizing the leading haptic, placing it into the angle, holding the incision with 1-2 forceps, piercing the sclera with the 30 gauge thin wall needle from the first mark, tunneling 2 millimeters and then diving down, grasping the leading haptic with micro forceps. Again, these are non-toothed forceps. And you want to hold it in such a way that it's not too far from the tip. There's a little bit of capsule there. Docking the haptic on the bevel of the needle, sliding it in, and it's in. Start to pull both needles out, the left one towards me, the right needle away from me. And then I have microforceps ready to go as I withdraw the left side needle. You want to make sure that not too much of the haptic comes out. And then I hold it very gently, stabilizing it, and then cauterizing the tip. And then do the same thing on the other side. Again, I have microforceps ready as I am withdrawing the needle to grab the haptic, making sure not too much of it comes out, and then cauterize the tip. I want you to pay attention to the profile of the haptic. You see how nice and flat it is? That means I have a nice scleral tunnel, which means that the optic is not going to sag back into the vitreous space, which enables a more appropriate and approximate effective lens position, the intended lens position for this lens. So perfectly centered now. You know, as I recall, I think this patient might have had a vitrectomy, and because I didn't really do a vitrectomy at the very beginning of the case. But I go ahead and do some vitrectomy through the trocar, making sure I don't encounter any vitreous, and I didn't. I'm going to go ahead and take each of the iris hooks out. With the two-handed technique, withdraw the stopper. I turn the hook 90 degrees in such a way that the open end is going to be rotated so it pops out. Although these hooks have been autoclaved just once and you can use them multiple times, you can see that the hooks are falling apart. So again, withdraw the stopper and then rotating it 90 degrees and it comes out easily. Now this is the surgical PI on the PI setting. The cut rate is very low. That's the most important thing. Aspiration rate is also low. And then you have a good vacuum because once you grab the iris, you want to get a good purchase and holding power. And then you're able to eat the iris and create a small PI. This is a 10-0 nylon suture to close my main incision and bury the knot. This is intracameral Kenalog. You can see again, no vitreous whatsoever. But I always do this just to make sure. And then hydrate the incisions. So again, this patient had low scleral rigidity. As I look back on the case, because it's been a bit since I've done this case, this patient must have had a vitrectomy because I would have otherwise done a vitrectomy early on at the case, but I didn't. Go ahead and withdraw the trocar, activate infusion, and I'm tamponading the sclerotomy, but I'm noticing something. Pressure feels good right here, so I go ahead and withdraw the AC maintainer. But as I hydrate my incisions, I can tell that the eye is not staying firm, and you can see ballooning of the conj. And so this means that my sclerotomy is not self-sealing. Go ahead and do a peritomy and a takedown of the conj. And so remember early on when I place my trocar needle, I like to tunnel and then go in straight down. And normally as you withdraw the needle, the trocar is tilted sideways. That tells you have a nice scleral tunnel. This one didn't have that. So that was a telltale sign that maybe I didn't have an adequate tunnel. And why did that happen? Because I performed the technique correctly. Again, I think this is because of the reduced scleral rigidity in these cases. And so it's no big deal. I did a conj cut down. You can see the sclerotomy very nicely here. There's no vitreous on the incision there. Go ahead and place an adovarcal suture, and then I go ahead and close the sclerotomy. And then I'm going to close the conjunctiva with a Matry suture here. And so again, with reduced scleral rigidity, you have more collapse of the sclera during the manipulation, even when you're trying to make your incisions, even placement of the trocar needle. And then, of course, when you're placing the needles for the Yamane technique, you can see quite a bit of indentation of the sclera. I could have put an AC maintainer early on. I chose not to. Again, you always have to balance the risks. In my experience, again, doing the lens exchange with high infusion, sometimes it can cause trouble and it might push the lens back. Again, because I don't put in pars plana infusion, which I've avoided thus far because I just don't feel comfortable doing it that way. And so these are all decisions you have to make, which pose quite a bit of challenges, even for people who are experienced with doing this type of surgery. But luckily and fortunately, the patient did well. I was mindful of these limitations going in. And that's part of the point, is you have to be prepared when you're dealing with these challenging cases, when to put in infusion, when not to, how and when to make your incisions. All of those things are intentional. You know, marking ahead of time. I always mark early on, because once you start making your incisions and you have water coming out from incisions and so forth, let's say, you know, we had a AC maintainer put in early on and you didn't make your marks yet, but let's say with the AC maintainer, there's a lot of fluid coming out. Well, now it's going to be very difficult to dry the conj and make your marks. And so I like to do all that before I put in infusion. Those are all, again, intentional steps, and the sequence of events are very important. I believe this patient had a vitrectomy in the past, and that is another reason why I was worried about that high infusion pressure early on, which can cause that lens to just fall back even further because there's no vitreous support. So again, all of these things you have to think about. You saw how I was able to externalize the leading haptic with a 25 gauge needle docking technique, and then cannulate the haptics through the needles with my modified Yamane technique, starting with the trailing haptic and then the leading haptic. And all of that part really actually was executed fairly easily without much fuss. The actual Yamane technique part went rather well. But it's these other things that pose potential issues, and it all stems from having that reduced scleral rigidity. Nonetheless, this patient did very well at the end of the case. So I hope this was helpful to you, and I thank you for your attention.